It's good to be back. This is ICM 27 edition of our medical reality talk show. And it's exciting to be back here again with Dr. Shraplat. I always struggle to pronounce her name. I know she's going to forgive me. Yeah, but I'm a ophthalmologist specialist who is our guest today. So today we're going to be talking about retinoblastoma, and the specialist in ophthalmology is here. Dr. Shrab Lad is a specialist in ophthalmology. She a graduate from the National Medical University in China, and then she moved on to Liberia, where she did her internship and also residency in ophthalmology at the Liberian postgraduate college there. So, and now she's currently doing fellowship in South Africa. So we're blessed to have, she's originally from India, by the way. So we're blessed to have an Indian, Chinese, Liberian, South African ambassadors, doctor, here with us today. So welcome, Dr. Pilar. Maybe you would like to briefly say something about yourself before we go into our discussion today.
Yeah, sure. Thank you so much, Dr. Bala, for having me once again on your show. I'm quite excited to discuss more on retinoblastoma because I've been always passionate about oncology. Since my residency, I've seen a lot of kids, especially they lost their life due to retinoblastoma. And there is very less awareness on retinoblastoma, not just in Liberia, all over world, especially in Africa. So yeah, oncology is my passion. And secondly, I'm very glad that I could do my fellowship in the field I'm passionate about, like in oncology and oculoplasty in South Africa. So yeah, thank you so much for having me again. I'm looking forward for our discussions.
Yeah, so that's really good. I know when this professional dream, before we go to that, this professional dream of being a doctor, there's a lot of excitement and different things about it emotionally. And sometimes you had a dream of becoming this and you end up becoming this, but it looks so interesting when you find yourself actually living that dream, not just the medical dream, but that area of specialization, you have passion in it. And I hope it's doing good with you there in South Africa. Of course, you are in one of the best African countries doing your specialization. How is it there?
It's all good, and especially my consultant and people here, they're quite friendly. Especially the regis in the hospital, the residents, they are quite nice. And yeah, I'm learning a lot. So I'm looking forward to come back to Liberia and give my best to Liberia.
Of course, you're not going
And
to India.
yeah,
You're coming to.
actually, I think I should really say this. Like, I'm really grateful to my consultant who looked forward, see that passion in me, and he offered me this fellowship.
God. Yeah, and I was just saying, of course, we are not going to allow you to go to India or China. You're going to go to Liberia. Yeah, but yes, very good having you, a very good friend and a colleague. So let's go to our discussion today. I know a lot of people have been looking forward to this discussion, especially about retinoblastoma, and probably the non-medical audience saw the flyer. Yes, retinoblastoma. They were like, I know probably what is that? Some people probably may not know. We want to talk about something related to the eye. But what is retinoblastoma? Let's start the topic on that very simple path.
Okay. So if you could share that first slide which I gave you, like the presentation we have, if we can share it
Okay,
along with.
sure, we can do that.
So basically, the retinoblastoma is like a cancer of the eye, where retina is the back part of the eye from which can help us to see better. So basically, the tumor, the cancer starts there, and it covers whole eye which can be life threatening, and also you can lose vision. But yes, people don't really know that cancer can happen in the eye. If you can see this image, you can see that's how a tumor looks like, the white reflex. We call it leukocoria or cat eye, where you can see that whole eye is covered white. Basically, this is the eye, which we call here as a retina, and there this is a tumor, cancer cell, which looks like a cotton ball, and which gradually get bigger and bigger and bigger, and it covers whole eye. So it's a second most common eye cancer after uveal melanoma. And it's the sad part of this cancer is retinoblastoma is only seen in children, and that too in the early span of life, like let's say sometimes they are born with that, or sometimes in their early stages of their life you can see
Let me
this cancer.
come in there. That pillar. Did I hear you say is usually seen in children, or is only seen in children? What is the statistic
It's
like, or the prevalence like
so it's
for
only
children and
seen
adults?
in children. Yes,
Only in children. Okay.
only in children. So it's basically a retinoblastoma is basically only seen in children, and it's the second most like commonly seen cancer in among all the eye cancers.
Mm. Okay.
So yeah. So basically
In
what happens is, just a medical term to explain what happens is, we have mutation in gene. So there is some gene called RB1. So there is some mutation of RB1 gene, which is on chromosome 13. So there is some changes which goes, and when these changes occur, it starts with the eye, and then gradually the tumor starts with the retina, and then gradually it gets bigger and bigger and bigger.
Okay, that was quite interesting, right? I like the information you gave us about it being more like only found in children, and the risk factor in terms of the genetic factor that play in there. But do you want to? I didn't hear that very well. I don't know whether you mentioned it. Do you want to give a little bit of statistics in terms of what is the prevalence like in Africa, maybe in Asia, or maybe also among different age range of children, 1 on 5 or something? Do you have that kind of statistics?
So it can be seen from like when a kid is born with it to a later stage, like let's say 10, 12, but the risk rate decreases as they get bigger. So most commonly it's seen between like 0, like when they are born, till the age of 5. That's the peak time when they can have this retinoblastoma, and gradually
Okay.
when they get bigger the risk rate decreases with that. But that doesn't mean that they shouldn't follow up. So in South Africa I've even seen a kid like who is following up after age of 12 or 13. So it's always good to do eye examination to pick it up at a stage when it's early
Okay.
or it's a small tumor. So as
So,
you asked about prevalence, so
mhm,
prevalence is like, in Asia and in Africa we have the highest, you know, prevalence of retinoblastoma seen. um, but the outcomes we also have in like in US and Europe, we do have cancer there, but the risk, I mean the chances of survival is better in those countries compared to Africa and in Asia.
okay.
So
So,
especially in Liberia, we don't really have any data on this retinoblastoma yet. That how many kids are having retinoblastoma, how many kids are dying with retinoblastoma.
okay, that could be a research area or something to look up to
Yeah.
maybe. get it. So
Yeah.
do you want to say something about the clinical features, the sounds and
Um,
symptoms? Stuff? Do you want a
sure.
slide?
So, yeah, we can put that slide on. Basically, as I mentioned before, the commonly kids are they present with second. Can you put the third slide, please?
Okay.
So, this was the kid. This was a kid who presented with leukocoria, which mostly when a parents like mother, most oftenly mothers and grandmothers in African countries, they notice this. So you can see it's like a white reflex, which mostly they will consider, oh, it's a cataract, but it's not a cataract. That's a tumor which is giving that reflex in the eye. So basically they comes, they think it's a cataract, and they go, especially in Liberia, I've seen parents, they go to herbals, like, traditional medicines and stuff like that. They think, oh, it's just a cancer, just a cataract, and which will go away with the herbal medicines. But it's basically a cataract, which is not a cataract, it's an cancer which is giving that reflex. Plus, that's the first sign. 60% of patients, they present with leukocoria. Secondly, the most common sign is strabismus, which we, in our layman language, we call it cross eye. Kids, they have cross eye because they are having some problem in the eye, and they can't really focus because of the cancer in the eye. I told you, mentioned before, it's in retina. So retina is the main thing which helps us to see good. So they also end up having strabismus, decrease in vision, or decrease in the movements of the eye. They cannot move their eye well. And also there are other signs and symptoms, which I just presented in my next slide. Can we have that one, please? So
Sure.
that includes, first picture is the same, leukocoria, and the second picture where you can see the black part, which we call as cornea. So it's basically, cornea is transparent, and which you can compare with the other eye. So in the second picture, when you see the cornea, it's just little opaque. It's not transparent like the other left eye. The right eye cornea is almost like opaque, and, like, there are some, if you can zoom it better, you can see some vessels coming on on the iris, which is going inside the eye. And the third picture, you can see there is some inflammation, like you call it uveitis. The eye is red along with the leukocoria. The fourth picture, you can see there is some white thing around the eye. So we call it pseudohypopium. Pseudohypopium is most commonly seen in the children with retinoblastoma. Hypopium is basically pus, but pseudo is something which mimic like pus, and it's actually not pus, it's the tumor cells. So and also in the picture, like on the fifth picture, you can see there is a lot of swelling around the eye. Sometimes patients present with orbital cellulitis, but it's which also is, like, one of the signs and symptoms in the kids which presents with retinoblastoma. So the last picture here, where you can see the whole tumor was, is pushing out whole eyeball. So it's almost the last stage of cancer, where you need radiation, and you have to take out the whole eye for the treatment. Yeah, so this is like orbital invasion, where the tumor is invading the whole orbit, and sometimes it also goes to the brain.
Okay. So talking about that, we want to go back to the discussion. What are some of the diagnostic modality? Like, this is something it's critical. So many children parents with these kind of children may not even know what to do. They may not know where to find help and may not have any idea what the outcome is going to be like. We want to share about some of the uh, diagnostic modality available. How can people find help that direction?
So there are a lot of diagnostic modalities which is available in out of Liberia, let's say, and there is so much limitation in Liberia. We are looking forward to progress on that. So basically, let's start from the basics. Okay, so we can do especially kids, if you're suspecting a tumor or a cataract and you cannot see the fundus because mostly the kids, they are not cooperative, you should do a B scan. So basically on a B scan, it's like we use some echoes where you can see some classic calcification, like some white stuff, like a tumor on the scan. So that's the basic one where you can do it in the clinic. And then later on, you can do, if you suspect a tumor or something, you should do examination under anesthesia. So most of the time, children, they are not cooperative in the clinic, so it's better to do examination under anesthesia, where you can dilate the patient is sleeping, and you can see the fundus, you can do the further treatment is required, whatever you want. So next comes is red cam. So red cam we use in South Africa. It's very good modality, what I'm really impressed with. So we use it just to document the tumor, whether there is any reoccurrence. So in red cam, you can see the first visit and the last visit of the patient, and you can keep comparing whether there is an increase in the tumor size, whether there is no increment in the tumor size, or whether the patient need chemo or any other treatment. After, you can keep documenting and monitoring it on a red cam. Then it comes CT scans and MRI, where you can detect the extension of a tumor, and also based on the extension, you can decide your management and the treatment. So
So
these are
just
the
to say
basic
this,
ones. Yeah.
okay. Just to pass this information for those of you that are following on Facebook or YouTube or Twitter, whatever, any of our platforms, and you can send in your questions. We'll be able to see it and we can be able to respond to that. We have a few minutes for question and answer. And those of you joining us here on Zoom as well, you have the opportunity if you want to ask a question. There is an emoji. You just go to more. There is an area where you can see raise hand. When you raise your hand, we will recognize you so that you can unmute your mic and ask your question. And if you don't want to speak, you can also just tap that in the chat room. We will be able to respond to your question at the end of the discussion. And so we will entertain questions. So whether from Facebook or YouTube, whatever platform you're watching us from, you want to ask question concerning the discussion, you can do that as we go ahead with the discussion. Yeah, so Dr. Pilar, thank you for that detailed explanation. I'm talking about the management. Uh, what are some of the available therapy, I don't want to say cute, but treatments, and whether in Liberia or in South Africa or in China, around the world, what are the available uh, treatments options?
Okay. So there are a lot of different treatment which is coming, but basically what I feel like, treatment before treatment, it's multidisciplinary uh, contribution, where you need all, you need your oncologist with you need a pediatrician with you need to counsel the parents, you need genetics, you need to find out whether there is any genetics involvement there. You need all those people to work along with you when you're making a treatment protocol or management. So I just completely don't believe that it's only the ophthalmologist who contribute in this. It's everyone. And it's not just before it
So,
was
so
easy.
usually we're talking to kind of very broad audience here. So usually the ophthalmology, that's the eye
It's the
specialist, right?
eye.
So we're gonna have the oncology. These are the people who specialize in treating the tumor, right?
Yeah.
And then we're gonna have the pediatricians. These are the people who specialize in taking care of the children. Yeah, so when you say multidisciplinary, I want people to get that as well. So it's not just the eye doctor, but the tumor doctor, the children doctor, all have to be included. Yeah, go ahead, Dr. Pila.
Yeah, so there is an involvement of everyone. So for the treatment, it's before it was easier. You can just remove the whole eye and then do the chemo. It's done. But now you should realize, as we are in 21st century, and then the thing is, the kids, if you don't have a eye or you're having an empty socket, how it feels like when they grow up. So you have to salvage the globe. That's the first thing. And second is, you have to save the life. If you don't have an option that you cannot save the globe, just go ahead and save the life. So the target we have, this international retinoblastoma grouping and staging, which was developed in 2003. Sorry, yes, 2003. So in that time, they have put this staging and grouping, which based on what type of retinoblastoma is it, like how big, and based on that they have decided the treatment.
Okay. So before we go to I see a question in the chat, but before we go to the question, I want us to go to the last thing here. Uh, what are some of the challenges in the whole management thing? I know if we mention one country like Liberia, the challenges we have are endless. So, but generally, what are some of the challenges in managing that? Especially you're talking about it involving multidisciplinary kind of treatment team. I know what that is like. We had a baby. We a tumor, a kind of olfactory growth tumor. And so we managed just a couple of days ago. We did the surgery, neurosurgery, but we have the ophthalmology, we have the oncology, we have the pediatricians. And I know morning in the morning we did the surgery, we go to do rounds. It was like everybody coming in. I know how that, but when the team is kind of well coordinated, it look very good. But there are many other challenges as well because these are different disciplinary, looking at it from different angle. But generally, what are some of the challenges in managing cases like retinoblastoma?
So before coming to the challenges, just a little bit description. So the things which are required for treatment of retinoblastoma is like chemotherapy. It can be intravitreal, it can be intravenous, intraarterial, or periocular. We can give all these are the different ways which I can. Intravitreal is like we are going in the vitreous and giving the injection. In periocular is where you can give the injection in the conjunctiva, tenons, or in the cornea or sclera. Then we come intravenous, where through the veins you give chemo. So these are the ones, and which when this all fails, then it come intraarterial, where you can give it in the ophthalmic artery. And from there, if it also fails, then the last is the radiation, brachytherapy and all. So when the tumor is small, okay, it could be managed with the focal treatment like cryo, TTT, or laser. So let's start with the challenges now. So there is very less awareness about the cancer in whole over the world, especially in our Liberia, where people don't know that cancer can happen in the eye. Secondly, chemotherapy, as I mentioned, chemotherapy drugs are very expensive in Liberia. Not all the patients, not all the families can afford it. And thirdly, if the tumor is in advanced stage, we have to mostly refer the patient out of Liberia for the radiation or further management. So not all the patients can travel out of Liberia for the treatment. So I remember during my residency, there was this young little girl who was 8 years old, and she have a tumor in the eye, same retinoblastoma. So she lost to follow up because they cannot afford the CT scan, MRI, it's expensive in Liberia. And then when she came back, there was the same, the picture I showed you in my previous slides, it was an orbital invasion. So the tumor was just growing in the orbit and everywhere. Probably, I don't think that kid have made it. So she lost her life because of the negligence of her parents. So if they could have taken that thing very seriously, we could have saved one life. So it's just an example, but probably there might be many more examples. So yeah, so these are the few challenges what I feel in Liberia. We have to be very much aware about the cancer. It's life threatening, and yeah.
Yeah, and I think one of the major challenge apart from Liberia, many of the low middle income countries is that uh, some of those diseases we discuss, even when so there are two major challenges. First of all, there is this ignorance, right, where people don't many times even take it serious because they don't know what it is. So information like this, other people who kind of like are not medical, but can be able to watch this kind of videos or show on social media. We have the information to be able to guide your family members. Like, oh no, I think I heard people talking, the doctors discussing this kind of thing before. This should be something serious. Let's go to the hospital. That's one aspect. We could be able to maybe reduce the challenge in that direction. But another major challenge is that many of those conditions, even at the hospital, even the little facilities that is available to be able to do something, many patients already cannot even afford. So come on, if you can't even afford
Yeah.
to do a CT scan, MRI, what can a doctor do? And so there
Yeah.
is already so the challenge is even a long way. I know many of the time some of those major diseases, patients are waiting for international kind of campaign where doctors come and during those surgery free before they can have a surgery. And so there is this global challenge sometimes. We hope that we can work around those kind of challenges in the future, that we don't have to wait for a global mission for a life to be saved. We can be able to solve some of those problems nationally. But yes, these are challenges and it's good to talk about. And so there are a couple of questions in the chat here. Let me start with that. It says, can I know why it's only found in kids? And how we know if we suffer from that as an adult or not? And so I think the person is concerned that you mentioned
Yeah.
retinoblastoma is usually found in children. And so why? Secondly, if you are a kid, you had it, maybe you didn't pay attention to it until you're an adult. To go into an adult life, how can you recognize it in your adult?
Okay, so it's a good question. So as I mentioned, it's not seen in adults. There are different tumor and cancers of the eye, which is seen in adults, but retinoblastoma is mainly in kids. So when kid is growing, so their retina is being formed at that time. So there is a changes in the gene, and there is a tumor formation at that specific time of when your retina is developing. That's why it's most commonly seen in children, not in adults.
So once you become either, if you develop any tumor in
Yeah,
the
your
eye, will
retina
not be
is already
retinoblastoma.
grown
Yeah.
and it's good. So that thing doesn't really happens in the adults.
There is another question here. Another thing I would like to know, um, what's the reason for this condition? I don't get it clear. I don't know whether you're talking about the causes of what.
So uh, maybe they're just asking what's the how it happens. So as I
Yeah, how it
said, there is a
happens.
gene mutation. There is a gene mutation, but there is a risk factor, family risk factor, and but yeah, mostly it's sporadic. There is no specific risk factor. It's in 5% cases it's like family history, and but in like 95% cases there is no risk factor, like it's sporadic.
There's another question here from Adrian Chad. I'm not going to try to call that name. I think he said, what is I think he meant to say prior. Can you see that in the chat room?
Okay, let me see. Okay. Oh, that's cryo. So, as
Prior,
I
yeah.
was mentioning, that cryo is a focal treatment which we usually use for small tumor which is less than 3 millimeter in the size, and also it's mostly in the periphery or at the equator. So it's a cryo is like a probe where you use, it's like a ice we use to freeze the tumor at minus 90 degree. So that's how it works. So it freezes whole tumor, and then you have to keep repeating it after 4 to 6 weeks. So
I think
basically,
Ajon
when you
is
do a
Ajon
cryo,
is with us here on Zoom. I hope Ajon, I hope your question is answered. If you want to do a follow up, yes, you can unmute to make a follow up. Okay. Uh, I don't see any question coming in yet from the Facebook. So I think just on the Zoom here. So is there any parting message you want to leave with us as we close?
definitely, like mainly because we have more people connecting from Liberia. So I just want them to be aware of what is like retinoblastoma is and how deadly it can be, because when they come in the last stage we cannot do much for those kids. If they come in the early stage and if they see a subtle or a little bit changes happening in their eye, in the kid's eye, or some difference, let them just go ahead and look for whole of the retina good. If they cannot examine well in a clinic, they can just go for examination under anesthesia where they can dilate the patient is sleeping and you can see whole of the fundus. But it's mandatory to do those things. And we have to be aware that cancer can happen anywhere in your body. So just be careful, especially those kids. They can't really handle those things. It's very sad to see them happening, going through all those things. So just be careful, and then I wanted us to work together. And so yeah, looking forward to that.
So thank you so much for joining us, and thank you for all of you who join us here on Zoom. Thank you for those of you watching from Facebook, from YouTube, and thank you so much, Dr. Pilar, for coming and taking up your time to educate us on retinoblastoma. I heard there was some special thing about retinoblastoma. Was it last month, this month? What was that?
Yeah, it's this month. It's a retinoblastoma week. So yeah, so that's the main reason I took this topic to discuss on. So just to create some awareness and let the kids, parents, and all the doctors and everybody, be aware what is retinoblastoma is, because yeah. That was the main reason for this topic, and I'm glad I'm back. Thank you for having me once again. It was pleasure to be here. Thank you.
Thank you so much. And yeah, I think I see a June coming back. Do we need to do routine follow up?
Yeah, as I mentioned, the cancer, it can be reoccur. It's a tumor. It doesn't stop. So once you do the treatment, you do intravenous or intravitreal, intraarterial chemo. There is a chances tumor can come back at any time. So you have to follow them up at least till age 12, age 13, until you really feel like, okay, the retina is good, there's no recurrence, there's no tumor. Yeah.
That's good. So thank you so much, and thank you for having you. Next week we're gonna be having we're talking about mental health as well this month. So next week Saturday again here same time we're gonna be having a psychiatric talking about mental health disorder, mental health disease, and how to work around those depression and all those stress and all of that. So we'll be glad to see you joining us next week, same time and same place. And we want to appreciate you for joining today. And thank you, Dr. Pilar, for such a wonderful and amazing presentation. It was good having you. We hope God bless you all and see you next week.
Bye.
Bye. Thank you.